Perfect. So my topic for today is atrial fibrillation. It's a very big and sometimes complex subject, so I tried to make it as easy as possible so that everyone can understand today. Oops. Okay. I want to go over the structure of this presentation with you really quickly. We're first going to start with the anatomy of the heart, then we'll talk about the conduction system of the heart, the definition of atrial fibrillation, its pathophysiology, the risk factors for this disease, the classification, clinical signs and symptoms, diagnostics, and therapy. Let me just activate my laser. Okay. So now onto the anatomy of the heart real quick, because I think you are all in different years of studying medicine, so I just want to explain it quickly. The heart consists of 4 chambers. This is the right heart, and this is the left heart. And now I'm going to explain the blood flow. So the blood is collected from the body and comes back to the heart through the inferior caval vein and superior caval vein. It enters then the right atrium, passes through the right ventricle, goes into the lungs through the pulmonary arteries, which you cannot see on here. Then the blood is oxygenated in the lungs, and then it comes back through the pulmonary veins into the left atrium, into the left ventricle, and then it gets ejected through the aorta back into the body. And now onto the conduction system of the heart. So the heart has its own tissue that generate electrical impulses, so the heart can pump the blood into the body. The heart's resting pulse is around 70 beats per minute. And the heart has its own pacemaker, which is called the sinoatrial node. So the sinoatrial node is the pacemaker of the heart, and the sinoatrial node generates electrical impulses. Sorry? Oh, okay. So the sinoatrial node... I think someone has their microphone turned on. Fatima?
Dr. Amira, can you hear me?
I think someone has...
You have authority, you can turn them off. And the participant section, you can click on the participants, and then there is an option, okay. You can mute everyone.
Oh, perfect, thank you. Okay, now, so the sinoatrial node is located in the right atrium, sorry. And the sinoatrial node generates those electrical impulses, and they travel through the atrium into the atrioventricular node, which is still located in the right atrium. And those electrical impulses then travel also to the left atrium. And this makes the atria depolarize, and this is when they start contracting. And then the electrical impulses travel from the atrium to the ventricles, through the bundle of His, and then to the left bundle branch and the right bundle branch. And you can see the left bundle branch also divides into 2 divisions. And when the whole ventricle has been depolarized, the ventricles start to contract and to push the blood into the lungs, respectively, the body. And this is a healthy pathway of the conduction system of the heart. And it starts with the sinoatrial node, which is very important. And this is why this rhythm is called sinus rhythm. So this is the healthy way. And now I want to talk about the disease today, which is atrial fibrillation. And in atrial fibrillation, I want to explain to you, is a irregular rhythm of the heart. So this is why it's called an arrhythmia, because it's not regular, it's irregular rhythm. And usually the patients have a very, very quick heartbeat. This is why it's sometimes called a tachyarrhythmia absoluta, because tachy means very quick. And atrial fibrillation is one of the most common arrhythmias. So you have to know there are several kinds of arrhythmias. Some are with a quick heartbeat, some are with a slow heartbeat. And atrial fibrillation is one with a very quick heartbeat and is one of the most common ones. The incidence increases with age, so it's more likely in the elderly people and is higher in males. So now, how does atrial fibrillation work? So I just told you about the normal conduction system and how it works, that it all starts in the sinus node, located in the right atrium, and then goes to the ventricles. And in atrial fibrillation, we have some abnormal cardiac tissue that generates electrical impulses. Usually they are located in the left atrium, close to the pulmonary veins. And they generate and depolarize the ventricle in a very, very quick way, with a beat of around 300 to 600 per minute. And what happens is that we have a re-entry mechanism in both of the atria, and it turns into a loop circuit of contention. Sorry, I just have to. Okay. Sorry, I'm having a problem turning off the microphone with my. Okay, now. So what happens? We have a re-entry mechanism in both of the atria with a very, very quick beat, and then what happens is.
باش اینجا بخوام نام که امروز لکچر میته.
Sorry. So when you have those atria that are depolarized in a very, very quick way, what happens is that the atria don't contract in a synchronized manner, but they start fibrillating. This is why it's called atrial fibrillation. And they start contracting very, very quickly, but ineffectively, and you don't get a synchronized output of the atria. And some of these electrical impulses may pass to the ventricles, not with a beat of 300 to 600 per minute, because no one would survive that, but maybe with a beat of around 120 or something like this. This is why the patients have an elevated pulse in atrial fibrillation. And some of these electrical impulses pass through the ventricles, but not all of them. And this is why the patients also have an irregular pulse, because some may pass, some may not, and this is why it's irregular, which you can also see on the ECG on here. Okay, now onto the pathophysiology. So atrial fibrillation is a arrhythmia that comes from above the ventricle. So this is why it's called supraventricular arrhythmia. And those abnormal cells that usually start in the left atrium, they're due to volume overload. So anything that stretches the left atrium of the heart that makes it bigger can trigger these abnormal cells. So for example, atrial hypertrophy or dilation, or volume overload, for example, due to mitral stenosis, when the blood cannot pass from the left atrium to the left ventricle as quickly, it leads to stretching of the left atrium, and this creates those cells. And they have bursts of electrical activity from automatic foci nearby the pulmonary veins. And atrial fibrillation is sustained by re-entry of electrical activity. And again, like I told you, what happens, they don't contract nice and synchronized like this, but they do this. They don't really pump well. And then what happens that we have a very slow blood flow through the atria. And if you know by Virchow's law, this triggers thromboembolisms. And one of the major complications of atrial fibrillation is actually a stroke, because a thrombus in the heart can travel into the brain and lead to a stroke in our patients. And it's very important to avoid this in our patients. So now to the risk factors of atrial fibrillation. So any general cardiac risk factor that we have for any cardiac disease can also trigger atrial fibrillation. So we have hypertensions with patients who have a blood pressure above 140 to 90 millimeter mercury. We have smoking, diabetes mellitus or obesity, which is called the metabolic syndrome, and also we have age. Age is a very important risk factor in atrial fibrillation. Then also any structural heart disease can lead to the patient ultimately having atrial fibrillation. So if the patient has a coronary heart disease, or if he's had a myocardial infarction before, if he has ischemic heart disease, valvular heart disease, especially mitral stenosis, because it leads to the stretching of the left atrium, and congestive heart failure, all of these can also trigger atrial fibrillation in our patient. And then we have the non-cardiac risk factors like pulmonary diseases, hypothyroidism, electrolyte imbalance, especially shifts in potassium. And then we have some sort of drugs, post-surgical states, so patients who have just undergone surgery are more vulnerable to atrial fibrillation and stress and lack of sleep. I think Akmal has a question. No? Okay. So those are risk factors that can all lead to the patient having atrial fibrillation later. Now, onto the classification of atrial fibrillation. So you have to understand this irregular heartbeat of the patient can happen at any time, but it can also stop at any time. So patients may be in an episode of atrial fibrillation at one certain point, and then they go back into sinus rhythm. So we try to divide atrial fibrillation into 3 different subcategories depending on the duration of the episode of atrial fibrillation. So we have patients who have a paroxysmal atrial fibrillation, that is atrial fibrillation that resolves within 7 days, either following treatment or on its own. So you have to understand a patient may have 1 hour of atrial fibrillation once a week, or maybe he's in atrial fibrillation for 2 months, or maybe 3 days. It's different for every patient. So the paroxysmal AFib is atrial fibrillation that stays for 7 days. We then have persistent atrial fibrillation. That is atrial fibrillation that is continuous for 7 days straight. And then we have long-standing persistent AFib. That is atrial fibrillation that has been going on for longer than 1 year straight in our patient. And you have to know that the longer the patient is in the episode of atrial fibrillation, the less likely he is to go back into the healthy sinus rhythm, which is very important to know. So those are the 3 different classifications of atrial fibrillation. So paroxysmal, which is sometimes, persistent, which is longer than 7 days, and long-standing persistent, which is the longest. So, now onto the clinical signs and symptoms. This is a little tricky one in atrial fibrillation because 80% of patients don't really feel anything, especially patients who have a long-standing persistent atrial fibrillation. They don't feel any symptoms. There are some patients who only have shorter episodes of atrial fibrillation, like the paroxysmal ones. They sometimes feel symptoms in their chest, and they may feel palpitations, so very quick heartbeat. They may feel dizzy, or like they're more sleepy, or they're having loss of energy, but it's difficult to feel when your heart is in another rhythm. We as physicians can sometimes palpate an irregular pulse in our patient's wrist. And then, interestingly, some patients only get diagnosed with atrial fibrillation after they've had a stroke, so one of the major complications. So we really have to make sure to catch atrial fibrillation before the patient has a stroke. And some are only diagnosed with atrial fibrillation afterwards. Some may also experience renal infarction or splenic infarction. So these are the complications that the patient may feel without knowing that he's suffering from atrial fibrillation. So now onto the diagnostics. It's very important to always do a proper anamnesis with our patient. So we have to have a good conversation with him, ask him about his past medical history, ask him about any symptoms he's experienced in his chest, if he's having palpitation, quick heartbeat, shortness of breath, if he's been doing lots of sport lately and then he's feeling weird, or if he has an infection, if he has stress going on, if he has been drinking alcohol, stuff like that. Then we have always to do a physical examination of our patient. So we palpate the patient's wrist for the pulses, like I already said you. We can auscultate the patient's heart, and we can check for edema, so for heart failure signs, so edema in the legs, swelling of the legs. We then have to do an ECG. And like I told you, some patients have atrial fibrillation at one point during the week, and then they go to the doctor, and in this certain moment, they do not have the episode of atrial fibrillation. So it's very difficult sometimes to catch the patient's episode of atrial fibrillation. So if he only comes to the doctor, I don't know, once a month or something like that. So what we can try to do is do a Holter ECG. This is a portable ECG that the patient wears around his neck, and it can monitor your ECG for 24 hours. And then afterwards, the doctors can check if they see any episode of atrial fibrillation. Well, there's also something called like loop recorders. Loop recorders are small, very, very small devices. They're like this, and they implant them underneath the patient's skin, and they can monitor the patient's heartbeat for up to 3 years. And then in this 3 years, you could check if the patient has atrial fibrillation. And then we as doctors, we also should assess the patient's laboratory and check for reversible causes, for example, infections, if the patient has electrolyte imbalances, especially shifts in potassium. And we should check for hypothyroidism. And then patients who have just been diagnosed with atrial fibrillation, you always should do a transthoracic echocardiogram and check for his ejection fraction, for valvular abnormalities, especially in the mitral valve. If we have mitral stenosis, it will lead to stretching of the left atrium, which can trigger these cells. And we should always check for thrombi in the patient's heart. So I just want to show you quickly this slide, because I think it's an interesting development in the tech area. Many people here wear the Apple Watch or other kind of smart watches that can check for your heartbeat. And it's very interesting because it's just a computer, and he has to measure your heartbeat, and he checks the ECG. And the computer can tell you, obviously, if your heartbeat is regular like this, or if your heartbeat is irregular like this. And then, for example, I think the Apple Watch tells you that the patient has an irregular rhythm and suggests to go and see a doctor. And I have seen many patients in the emergency unit that came to me and said, oh, I have more symptoms now, and my Apple Watch has been saying this or that. Can you please check with my heart? So I think it's an interesting development. The Apple Watch obviously cannot detect a myocardial infarction or something, but it can check if your heartbeat is regular. So now the most important thing to diagnose a patient with atrial fibrillation is the ECG. So I just want to go quickly over the ECG with you again. I don't know, maybe you know it already, maybe not, then it's, I hope you understand. So this is ECG, very simplified. It's in a healthy patient. What you can see on here is the contraction of the atria. So the atria contract. This is in this small little P wave on here. Then the electrical impulses travel through the ventricles, and then we get the contraction of the ventricles. This is why we have this big peak here. This is also called the QRS complex. And then afterwards, we have the repolarization of the ventricles. So this is in the T wave. And then this whole cycle starts again. So we have P wave, contraction of atria, QRS complex, which is the contraction of the ventricles. And then afterwards, we have the T wave, which is the repolarization of the ventricles. So this is in a healthy patient. And we always see the P wave, and this is called sinus rhythm, because whenever we see a P wave, we know that the atria are contracting in a nice way, and we have sinoatrial node, which is located in the atria. So it's a nice and healthy rhythm. It's sinus rhythm in our patient. Now, This is ECG from a patient with atrial fibrillation. I will leave you to look at it a minute. Maybe someone wants to describe what they see.
Madam, the P
Dr.
wings are not exactly visible.
Very good, yes.
Yeah, and our interval is irregular.
Very good. I think Amna also wants to say something.
And also, the rate is abnormal, irregular.
Sorry? Exactly. So I think I heard.
The rate is irregular.
Very good, yes. So you all said correctly. When we check for an ECG, we first look if we can distinguish a proper P wave. And what you can see on here is it's very difficult to say which one is the P wave for the following QRS complex. And there are many small waves that are not really easy to distinguish. And this is also due, like I said, to the fibrillating of the atria. So they make a lot of noise, but they don't pump synchronized. So this is the first criteria which we look at in atrial fibrillation. Can we see a P wave? We cannot really distinguish one on here. And the other thing that you already said is that we're looking at the distance between the different RR intervals and at the distance between those QRS complexes. And now we see on here that, for example, between each and every one of them, between those, it's a longer time. Then again, we have a shorter period, and then here again like this, and then afterwards it's a longer period again. So what we see on this small part of the ECG is that the heartbeat is very irregular. So those are the most important criteria in ECG. We should always check for the P wave. If there is none, it suggests that, well, it's of atrial fibrillation, and check if the heartbeat is irregular. So, and this you can also see obviously on Holter ECG, on the long-term ECG, or on event recorder. So the ECG is a very, very important tool for atrial fibrillation. Now that we have diagnosed our patient with atrial fibrillation, we want to go on and treat him of this disease. So now to the therapy of atrial fibrillation. So there are two main concepts that we follow when talking about atrial fibrillation. One is the heart rate control, where we try to control the patient's heartbeat. And one is the rhythm control, which can be done electrical or pharmacological, where we try to restore the patient's heartbeat in a sinus rhythm. So first, let's look at heart rate control. So heart rate control is the therapy where we try to suppress the patient's heartbeat to a slower rate. For example, they might be in a heart rate of around 120 beats per minute. And this can feel very uncomfortable, and it's very quick, and the patient might be feeling short of breath or something like this. So we try to suppress his heartbeat to a target rate between 80 and 100 beats per minute. Note that you should always correlate this clinically with your patient. If he's feeling fine with a heartbeat of around 85 to 90, then it's completely fine. You don't have to suppress it until it's 79 or 75 something. You should always check in with how your patient is feeling. And if he's already feeling better, if he's having no more symptoms, then this is completely fine. The first line therapy in Germany to treat a very quick heartbeat is called beta blocker. We usually do this with bisoprolol or metoprolol. If these drugs don't work, the alternative would be calcium channel blockers like verapamil. And in some patients, this may already be sufficient of a therapy. So you treat them with the heart rate control, they feel better, everything is fine, perfect. We never catch an episode of atrial fibrillation again, bye. But with patients who have a longer episodes of atrial fibrillation, we try to do rhythm control. So what exactly is rhythm control? In rhythm control, we try to restore the patient's sinus rhythm, and we do a cardioversion. So cardioversion just means that you want to convert the patient into a healthy sinus rhythm again. Before we do cardioversion, we always have to do, very important, we have to make sure that the patient does not have a thrombus in his atrium. Because like I already told you, patients are more likely to have a thrombus in their heart. And when you do the cardioversion, it could happen that the thrombus dislodges from its place, so it can travel to another place, and then it goes up into the cerebral arteries and will cause an ischemic stroke in our patients. So we really want to avoid this before we do the cardioversion. So we check the thrombus. How do we do this? You can either do a transesophageal echocardiography, or you prescribe anticoagulation to your patient 4 weeks prior. And it's very important then the patient is compliant and you really trust him and he does take those anticoagulation. And if he does so, then you can safely proceed to cardioversion. Cardioversion can be done either with drugs, so in a pharmacological way, or it can be done with electrical shocking. Now, let's look at how we do it with drugs. So this is called pharmacological cardioversion. And here we see the classes of antiarrhythmics. And you have to know that when giving a drug to a patient, you always have to think about this drug will have maybe the desired effect. It will also have side effects. It might also interact with other drugs the patient is already taking. So it's a little tricky. For example, those are all antiarrhythmics for different kind of arrhythmias in the heart. But all of these arrhythmics, they used to treat arrhythmias, but as a side effect, they can all also trigger arrhythmia in our patient, which is a little stupid. So you have to be careful with drugs. And then also the first line therapy to do pharmacological cardioversion would be flecainide. But flecainide is not approved for patients who have underlying cardiac issues. So patients who have had a stroke before or suffer from coronary artery disease, you cannot prescribe them flecainide. And like I already told you, many patients already have one cardiac disease and then they have atrial fibrillation on top of that. So it's difficult to actually find patients that can use this kind of medication. Actually, the only drug that can be used in patients who do have a structural heart disease and atrial fibrillation is amiodarone. But because it's very tricky with these drugs, in Germany, we usually do a electrical cardioversion because I feel like it's safer to proceed sometimes. So let me explain to you how the electrical cardioversion works. So I have a little picture on here. So the patient comes into hospital and you decide, okay, we want to restore sinus rhythm in him. He has been having a lot of episodes of atrial fibrillation. He doesn't feel good. We will do electrical cardioversion. What happens? So you apply the electrode on the patient's chest like this. You can see it on here. Then the patient is monitored. We see his heartbeat, which is irregular, as you can see. And here there are different distances between each and every one of the QRS complex. The patient is then sedated because it can be very uncomfortable. And then the patient is giving the electrical shock with a current of around 150 to 200 joules. And like I told you, the atria fibrillating like this, and then you have to imagine that you give them one big shock and afterwards they start pumping synchronized again and better. And afterwards, you see that the ECG is regular again. This is very complex, so I thought it would be interesting for you to see a video. Let me just check if I can open the YouTube video quickly. Can you all see the YouTube video?
Yes, we can see the stuff.
Okay, perfect. So this is the defibrillator. We are in hospital. The patient is somewhere in the back, you cannot see him. And on here you see the patient's ECG, and you can already see the patient's pulse, which is very fast.
Atrial fibrillation, thinking 200 joules.
So what this woman is doing, she is syncing the defibrillator to the patient's QRS complexes. So the computer knows exactly when to give the shock to the patient to make sure that it's really synchronized with the patient's heartbeat.
Charging.
So now she charged the defibrillator to 200 joules, as you can see up here and also here. The defibrillator is now charged with 200 joules, but he has not given the shock yet. Before you give the shock, you have to push this little red button here. And before you push the button, you have to make sure that everyone stands clear of the patient's bed. So do not touch the patient, not his body, not his bed, whatever, because otherwise you might be given electrical shock, which is very dangerous. So you make sure that everyone stands clear. And the woman is now going to give the shock to the patient. And I want you all to watch the ECG of the patient and his pulse.
All clear.
So now look at what happens to the ECG. It's taking a few seconds, but it's starting to become more regular.
Sinus rhythm.
And also the heart rate is going down. I think you saw. Yeah, you saw it at the end. So this is how the electrical cardioversion works. Now, so yeah, and some patients may have one electrical cardioversion and they're completely fine afterwards. In other patients, you do it, I don't know, times a year, or others have 4 electrical cardioversions in their whole life. It's different again for each and every one. So you should always ask the patient if he has had electrical cardioversion before and if it has worked fine for them. Then we have one last procedure that we can do in patients who failed the cardioversion or the antiarrhythmic drugs. So this is a very specialized procedure. It's called the pulmonary vein isolation. And what the doctors do here, they enter the patient's blood or patient's heart through the inferior cable vein. They then go into the right atrium and then pass onto the left atrium, and they enter with 2 catheters. One is the mapping catheter and the other one is called the ablation catheter. And what do they want to do? They want to find the cells that trigger those abnormal electrical impulses. It's a very complex procedure, and with the mapping catheter they can find out, okay, which ones are the cells that trigger those electrical impulses for atrial fibrillation in the patient. And once they found out with this mapping catheter, they're going to use the ablation catheter, and they will apply extreme cold to the tissue and basically kill the electrical impulses from the cells. And then afterwards, the patient is cured of atrial fibrillation, which is very interesting. But you usually use it very later on in the disease. If nothing else has worked, we try this, and this is done in very specialized hospitals in Germany, and it then has a success rate of around 60 to 70%. So this is how you treat a patient with atrial fibrillation. One of the very important things I want to tell you about today, this is the last point. Oh, I think Amna has a question.
Yes, dear doctor, just one question.
Yes.
What is the way between the atria or interarterial septum that we enter the catheter from the right atrium to the left atrium? And if we enter that, does it not create any complication when we remove it? There may be some content or some thing for that left behind after removing of that cable out. So
Yes, I know what you mean. I always ask myself the same questions. But I think they enter through the vein because it's easier to go with the blood flow back to the heart, and then the inferior cable vein enters the right atrium, and then they pierce through the septum. That is true, but it's a very, very small hole, and they poke through it, and afterwards when they go back, it will just close again. So usually there are not that many complications from this procedure. So I always ask myself the same question, actually, but I think it's because it's easier to go through the venous system into the heart, and then they have to go through the right atrium into the left atrium.
Thank you, Doctor.
Okay. So the last point I want to talk to you about today is the prevention of complications. And like I already told you, the major complication, which is very seriously, has to be taken very seriously, is a stroke. Because patients who do have atrial fibrillation, they suffer from thromboembolic events. So very dangerous, and we want to assess that. So how do we do this? To prevent the patient from having a blood clot or a stroke, we have to thin out his blood, right? And we do this with anticoagulation. And we do this in patients who have a positive CHA2DS2-VASc score. So what the hell is a CHA2DS2-VASc score? I'm going to explain to you. The CHA2DS2-VASc score, this is a clinical score that helps you to decide whether you should give the patient anticoagulation or not. It's actually an acronym, so each and every one of those letters stands for a different disease. So we have congestive heart failure. This will give 1 point to our patient if he's suffering from this disease. Hypertension, this will also give 1 point. Then we have AIDS. So patients who are above 75 years, those will get 2 points because age is a very important risk factor for inflammation. We have diabetes mellitus, which is also important risk factor. Sorry.
Jose, please turn off your mic. Thank you so much.
I think I don't know. I'm not sure how everything works with the technology, but I try.
It's totally okay. Thank you so much for your time.
So we have diabetes. This will also give our patient 1 point. Stroke. Stroke is a very important risk factor as well. So stroke will give our patient 2 points. Vascular diseases like the coronary heart disease or the peripheral artery disease will also give the patient 1 point. Then we have age again. Age between the age of 65 and 74 years will get the patient 1 point. This is a little stupid that we have age 2 times in this score. I think it's just how it developed over time. But you have to know that age is a very important risk factor for atrial fibrillation. And then we have sex. If the patient is a female, she will also get 1 point. And you can see in this acronym that after the letter A is a 2 and after the letter S is a 2. So you can know that age is an important risk factor because it gets 2 points, and stroke is an important risk factor because it also gets 2 points. And you don't have to know the score by heart, especially if you're not working in cardiology, but you should understand what it's trying to tell you or how to use it. And there are many calculators online that help you to calculate the patient's risk. And you should consider giving the patient's anticoagulation if it's a man and he has above 2 points, and if it's a woman and she has above 3 points, then we should prescribe anticoagulation. So again, there are 2 different drugs that we can prescribe for patients with atrial fibrillation. One are called the vitamin K antagonists like marcumol or warfarin. And you have to understand that you're preventing a blood clot, so you're thinning out the patient's blood, but he's also more likely to bleeding. And especially in the elderly patient, if they trip and fall and they hit their head or something like that and the blood is thinner, then what might happen that they have a high risk of major cerebral bleeding, and then we get a hemorrhage in the brain, which is also what we don't want. So you have to always be careful with your patients with anticoagulation and always explain to them what happens as well. But the vitamin K antagonists, they're actually approved in patients with valvular diseases. So like patients who have atrial fibrillation due to mitral stenosis, like I already told you, and in patients who have a chronic kidney disease. And then we have the newer kind of drugs. They're called DOACs, so they're direct oral anticoagulation. They're more popular nowadays, especially in Germany. We more and more prescribe these drugs, and they're called apixaban, rivaroxaban, edoxaban, or dabigatran. And they all inhibit different factors of the coagulation pathway. And the studies have shown that these drugs actually have a reduced risk of a major cerebral bleeding compared to the vitamin K antagonists. And this is a nice thing for us because we're very afraid of patients having a hemorrhage when we thin out their blood. But with the DOACs, we have to be careful in patients who have a chronic kidney disease because these drugs are eliminated by the kidney. And if the patient's kidney is not functioning properly, then the drugs will accumulate in the patient's body, which is also not good after all. So this is how you treat the complications. So this is how you want to prevent a stroke in our patient. So this actually is everything I have to tell you about atrial fibrillation. I know it's a very big subject. So I have the key takeaways for today's on one last slide again, so that you can remember what we just talked about. So atrial fibrillation is a cardiac disease with a fast and irregular heartbeat. So it's a tachyarrhythmia. Most patients don't experience any symptoms at all. It's very difficult to catch any symptoms. The most important investigation is the ECG. Like you already said, we should always check for the P wave and for the different RR intervals in the ECG, very important. And then the treatment options include the heart rate control, where we try to suppress the patient's heartbeat, and the rhythm control, where we try to restore the patient's sinus rhythm, and we usually do this electrical. And the major complication of atrial fibrillation is a stroke. We always want to avoid patients having a stroke, and this is why we always assess for anticoagulation in patients who have atrial fibrillation. So this was my presentation on atrial fibrillation. Do you guys have any more questions? Is there something that you did not understand?